We are back to the People's Policy series, and I wanted to bring up an issue that I have been personally and passionately fighting for my entire life, which is women's autonomy, our right to personal sovereignty, to be ourselves, and to make decisions over our lives and our bodies. And I wanted to share with you how this started for me. It started because I lost someone. A few weeks ago, a colleague of mine, Andrea Miller, the CEO of the National Institute for Reproductive Health, passed away. And she passed away in her sleep, and she was in her early 50s. And no known health problems. My heart feels like I hope all the stress that she undertook, getting reproductive rights, but women's gender and just women's rights at the forefront, being respectful and loving, that it's really a deep loss, not just for me, but for all of us. We just don't all necessarily know it yet because, I don't know that a lot of people knew who she was, but she was an advocate for all races, all ethnicities, all religions, completely centered in love and empathy. And at any rate, I feel like today we're going to, in talking about reproductive health on a more global scale, on a hemispheric scale, and talking about the consequences of holding women back, or women feeling like they have been held back, means quite a bit for us today, even in the United States, as we struggle through our own conversations. Now, this brings me to today, right? And so I've invited two doctoral candidates from George Washington University, Kelly Umaña and Bridget Kelly. And our goal, as we talked, because this conversation with Kelly initiated with the passing of my friend, and I shared my story with her. I didn't know all these things that Kelly was doing, or her colleague, Bridget. They have really helped me to see the work of women and reproductive health in a different way. And I hope today we have a rich discussion. There's just a few of us, about women's health and the impact of policy on their lives, and how it can lead women to really take some difficult choices, drastic choices, to keep their autonomy and personal sovereignty, to benefit themselves and their families. They are, looking between migrating, leaving, or even sterilizing themselves. So we will explore the research and advocacy that Kelly and Bridget have been engaged in related to the expansion of liberalizing reproductive rights in Latin America, but also the converse, how harsh decisions taken by some governments have created an environment where Latina women are forced to consider sterilization as their only option. So what does gender inequality really mean, and what are its impacts? Here in the US, we've seen a lot of discussion around the Supreme Court decision, Roe v. Wade being overturned, and Roe v. Wade guaranteed a constitutional right to abortion. That is not what we're doing here, though it does provide a context for our discussion. Governments around the world are making important decisions about women's ability to control their bodies and their lives. Some of the decisions are very restrictive, leading to mental health challenges, physical challenges, and even suicide. But some countries are also fully embracing the recognition that women are valued citizens and are critical to the advancement of their nation, socially, economically, and politically. So today we're going to explore Bridget and Kelly's research and advocacy on these issues. And, my hope is we gain an understanding of the what's, right? Governmental actions, potentially, what does that mean for gendered migration, how women migrate, and the potential and well-being of their own countries, where women feel they have no other option but to either sterilize themselves and or leave. So what does this mean for us here in the US? What does it mean here in Maryland? So a little housekeeping. This can be a sensitive and controversial topic. So I hope what we do here today is to be inclusive. Everyone has an opportunity to be heard, that we be gentle and respectful of one another, and listen actively and with undivided attention, because I really feel it's important we understand where people are coming from. Also, if you're new to us, place your name and organization in the chat along with your county, and put your questions or comments as we speak, or lift your hand. So Kelly, Bridget, let's get started. I always like to begin with an introduction. So let's start with you, Kelly. Tell us about your work, tell us about yourself, and how you got started in all of this.
Yeah, so just a little bit about me. My name is Kelly Umaña, and I am a doctoral student, but I'm also I've been working in public health for about 10 years now. It's crazy to think of it that way. I actually started off my career in maternal and child health. I interned at the Maternal and Child Health Bureau and also worked at the Association of Maternal and Child Health Programs. I pivoted my career a little bit due to some circumstances around my own women's health and my own reproductive health and decisions I had to make that meant most for my family. And so I'm now, partnering a lot with Maryland Latinos Unidos, working directly in the Latino community. My interest has always been addressing these critical health topics, especially within Latino and migrant communities, especially because that's the community I come from. My family's from El Salvador. So this topic actually came through an assignment I had for my doctoral program to pick a specific topic that I was interested in. And I knew about some of the things that were going on in El Salvador, but not deep enough to have a conversation about it. And I did a deep dive on understanding what are some of those reproductive health rights. And a number that was very startling to me was that 54.4% of women from El Salvador, ages 15 to 49, were choosing sterilization as their method of their main method of contraception, specifically more predominantly within youth and younger populations. I wanted to get a better understanding of what was behind that number, what was going on, what were some of the implications that were going on. So I'll probably talk about this later on in the conversation, just to give some historical context, but that's how I got into the topic, and was very interested in diving deeper into my own culture.
I muted myself. I apologize. I was saying thank you, Kelly, and that's the personal story is always, I think it makes it real for all of us, right? And Bridget, tell us about yourself and your journey.
Yes, good morning to everyone, and like a very, very huge thank you to everyone for inviting me into this conversation today. I just want to, Gabby, recognize Andrea Miller as well, and thank you for dedicating today's talk to her and her work. And I just love this idea of centering this with compassion and empathy, this conversation. I feel like if we can take that forward in all of the work we do, we can really make some big strides when we talk about gender equality. So thank you for that. Okay, so I got into this line of work looking at reproductive health and rights as I joined the Peace Corps volunteer as a very young and naive 22-year-old. I was placed to serve in a very small community in Ethiopia. And again, I walked in thinking I was out to save the world as this really knowledgeable Peace Corps volunteer, and I was hit with intense humility immediately, realizing I knew very, very little. But what I did learn through my almost 3 years there were some truly strong life lessons around what my passions were and what fueled me when it comes to forging a career in sexual and reproductive health and rights. And truly, primarily, I just learned a lot from working there about what was being implemented in Ethiopia and then taking that back to the US, because I wasn't seeing those same conversations happening without such hesitation here in the US. And so hoping to really start having more conversations that looked at our domestic issues here. But one instance that really brought me to this work was I was teaching about HIV transmission through an English course in Ethiopia. And I recognized that most of my students were males, high school level. And I kept thinking, like, where are the girls here? And occasionally some girls would join us, but their attendance was intermittent. And later on, maybe a couple months later, I went to the hair washing salon and asked, like, you know, do you girls want to come to my class? And one of them said, oh, no, I'm menstruating this week. I'm you know, I have my period. And it like hit me like a ton of bricks. Like, what do you mean you're not going to class because you have your period? And it was this instance that I realized how important having access to good menstrual health is to all of these other issues that I was working on or trying to work on. And so if you don't have these basic level provisions, then all of these other efforts are inevitably weakened. And so that brought me to, truthfully, I didn't have the skills to even comprehend what to do with that information. And so I sought out more academic and professional training to approach these topics. And that led me to working at the Population Institute, which is an advocate group here based in Washington, D.C. that advocates both domestically and on the international level for universal access to reproductive health and rights through various different research and educational efforts. And so my interest lies in taking complex pieces of research and translating them into action and translating that into pushing policy in the right direction.
Love it, love it, love it. Go ladies. So everyone in this group is pretty well versed and compassionate around this front. So it just happens to be because we're a small, there's just a few of us. But I want to talk first about definitions, I guess, and why sexual and reproductive health and rights important to other areas of health and well-being. Bridget, you started us in on that, and actually so did you, Kelly, with your personal story. In the bigger sense, how do reproductive health and rights, how do they play, what role do they play, and how are they important in other areas of health and well-being? Both of you.
Go ahead, Bridget.
Okay, thank you. And I do really think it's important to define what sexual and reproductive health and rights are. Oftentimes in a lot of conversations that I'm involved in here domestically, there's been this conflation of equating reproductive health to only abortion. And I want to say that abortion is a very critical component of sexual and reproductive health and rights, but it's not the only component. And so when we do that, we are overlooking and ignoring some other really important pieces that maybe aren't so contentious or so taboo. So I've compiled the list of core components as recognized by major advocacy groups, but also like the World Health Organization and the United Nations. And so it includes comprehensive family planning or contraceptive services. It also includes maternal health. And so this is where we run the risk of ignoring some really important issues when we talk about maternal mortality rates, especially here in the United States, if we are only thinking about contentious issues. It also includes the provisions of prevention and treatment of infertility, which is a often overlooked aspect of reproductive health. It includes STI, HIV, and AIDS prevention, care, and treatment. It also looks at reproductive tract infections, reproductive cancers, and also really important to this conversation today too. It is looking at the prevention and treatment and care of gender-based violence. And so that would include screening, counseling, and referral services. And now I would personally just like to make a little note here. Kelly knows my passion about menstrual health. Menstrual health is often excluded from this list There's a growing movement right now.
Why is that?
Because it's typically housed on the international level, it's housed under the water, health, and sanitation and hygiene, because it was first labeled as menstrual hygiene. So to get funding for it, they house menstrual health under WASH, but the water, health, and water, sanitation, and hygiene sector. But that is predominantly led by male engineers. And so when they focus on this, it's mostly a focus on toilet infrastructure and maybe just the provisions of menstrual materials. But we know that there's like a greater issue talking about stigma, talking about the economic impacts that period taxes have, taxes on period products, and the expense of it. And so in my opinion, so my work right now at the doctoral level is to really push to have this included within reproductive health. It feels like a natural fit to me.
Well, it's together, right? It's sexuality and reproductive health, and both impact the other. What about you, Miss
Right.
Kelly?
Yeah. It's the start of our reproductive journey is menarche.
There you go. There you
So
go.
it seems like a natural fit.
Exactly.
But I mean, and this kind of goes into our conversation when there's restrictions now on certain aspects of reproductive health on the policy level, but also on the funding level. There becomes a concern of how do we fund yet another component when our funding is being cut now. So there might be a flip side to that coin too of is housing it under sexual and reproductive health and rights beneficial for menstrual health? So those are questions I hope to explore further on.
That's new territory. Kelly, any thoughts?
Yeah, so I started my introduction with my personal experience I had, and your question around how does sexual and reproductive health rights impact other aspects of our human autonomy. And I had to quit a job because I wasn't given the opportunity to breastfeed my child in a way that was right for me, from the way that I felt was most comfortable for me to be able to feed my child. For me, my priority was to breastfeed my child, but I wasn't given that opportunity at a job. So I had to quit my job. And that was a huge financial economic loss for my family. And we had to, my husband had to take another job. I had to stay home with my child. And that's where I had to pivot in my career, given those constraints. And so I think about that more for me, like on an individual level, but I also think about it in the aspect of our Latino community, our immigrant community, who not only has a lot of instability in their jobs. They don't have access to sick leave. They don't have access to family leave. They don't have the ability to have these conversations in their workplaces. So that is a huge economic loss opportunity when we don't have systemic policy changes or systemic conversations around our human autonomy and the decisions that we can make for ourselves to feel empowered. And I know, Bridget, you and I talked about this around how you might be able to give the global number, but I know in menstrual health, especially for girls, young girls, you can miss 0.4 days of class, given the fact that in the US, given the fact that you don't have access to menstrual health in your schools. And so we think about that on an education level and what that means for girls, especially our Latino communities, our immigrant communities, our Black and Brown communities. What does that mean when they also have additional social determinants of health that they have to consider? And I think for me, as I'm diving into this topic more so, what it looks like in Latin America, what it looks like here, what those relations look like, because we know we have a huge Latino community here in the US, especially in Maryland, where there's a huge Salvadorian diaspora. And so I think there has to be a lot more conversations around, we know, as Bridget mentioned, there's the conversations around abortion. We also have to think about what are the other trickle down impacts when there's a rollback on sexual and reproductive health rights, what that looks like around education, economic opportunities, what that looks like in terms of our human empowerment that we should have, that we want to have, and making these decisions for ourselves. So I think there's a broader conversation that needs to have about that.
Right, right. Maria has been very patiently with her hand raised. Maria, do you have something you'd like to share with us?
Hi, yes, it's Marla Posey-Moss, and I
Oh,
apologize.
Marla, I'm sorry, my glasses.
It's no problem. I'm Maria half my life. So I apologize for not being able to have on my video. Just want to give you some context. I'm the past president of Free State PTA, which is the state PTA, and I'm currently on the board as the vice president of leadership. So we do training. And so one of the things that struck me, Bridget, because I've been to all women's school, when you talked about when you're in Ethiopia and that young lady couldn't attend your class because of menstruation, something that we really can't conceive of, having that setback here. Do you think that part of it, outside of religion, do you think that part of it may have been capital infrastructure? Because here we're able to go to bathrooms. Mm-hmm. Some bathrooms have pads and tampons that we can buy and purchase, or was it more like a taboo thing where you can't go out anywhere, whether it's to the store or anywhere else, much less a class? So do you think like we can go to the bathrooms here at our restaurant, gas station, whatever? Do you think it was an infrastructure type issue as well?
Yes, there is no denying that it's part of an infrastructure issue contributes to the problem. I think when we look personally, I never used the bathroom at the school. They were in a very dismal state. Like I didn't feel safe. There was not a door on the bathroom. But B, it was just not a hygienic place to want to manage my menstruation there. So no, I absolutely thank you for bringing that up, Marla. Like it is a very important piece to that. But additionally, it is such a taboo topic, and I would argue that that's not specific to Ethiopia, to that context. I also find myself having some difficult conversations here in the U.S. with regards to menstruation. And it's because it's often touted as like a dirty or private issue, and yet half of the world experiences it. And so as Kelly said, there's some implications to the rollback of our reproductive rights that I think are unforeseen. And a lot of my research is looking at what these policies have on menstrual health. And so one issue that's not discussed often, but is upcoming more and more, is the use of contraceptives, certain hormonal contraception, to manage menstrual disorders. So that's like heavy menstrual bleeding or endometriosis, which can, as Kelly was mentioning, it can prohibit people from being able to go to work, to go to school. And so we're seeing that some policymakers, specifically one in Idaho, has been very emboldened by the overturning of Roe, and is now saying that certain methods of contraception cause early abortions. The data, like from medical providers, are saying no, it's and a hormonal IUD is inserted into the uterus, and it prevents the sperm from actually fertilizing the egg. So in the definition of an abortion, it doesn't match that. But this type of nerve-wracking talk is what's actually fueling a lot of the debate around restricting contraceptive access or certain forms of it. And so if we step back from just that conversation around some types of contraception as abortifacient, what does that mean for people who depend on this type of contraception to participate in society on a daily basis? Those are some of the questions that I don't think a lot of policymakers are considering when they're quick to want to want to restrict certain aspects of our reproductive health. But I know there are plenty of people who depend on these types of IUDs to be able to not have severe cramping monthly, and not to, you know, heavy menstrual bleeding. That can be extremely infringing on your daily life. So while the typical individual menstrual flow might go through 6 or 7 tampons, let's say, a day, heavy menstrual bleeding could be upwards of 20 tampons a day. So that has a financial impact, but that also has, you know, do you have access to restrooms at that rate? Are you then needing to just stay home because you bleed through your clothes, and that is embarrassing to you? So there still is an element of stigma that I'm seeing here in the U.S. too.
So Bridget, let me stop you here, because I feel like what you just said about how policies impact things in other ways, or have the potential to, and they, you know, in favor or against. I want to go to Kelly, because she and I, when we first started this discussion, we were talking about specifically El Salvador, and you shared a number with me, a statistic that you just mentioned. I think you said 54.4% of women 15 to 45 are getting sterilized. And I think this is really a moment also where you see the impact of policy on a woman's life, right? And you were explaining that you did this literature review and about recent legislative changes and sort of just the bigger picture of it all. And it was just really striking to me, one, because I hadn't heard about it. And, you know, I think I know everything, right? Which is, it's another problem. But so I was excited to learn something new, but I was also, it's tragic. So tell us a little bit about what you've learned and what you think are some of the root causes of this, how this might influence migration, for example.
Right. So I can definitely speak to El Salvador and kind of what my findings are, but I definitely want Bridget to talk about it on a kind of more international scale and what that means. So just to give some context, El Salvador is one of 4 countries that rolled back abortion laws, making them completely illegal and punishable by law. So in 1997, they established this law. And I looked at the articles of the policy that was put in place. And just to give you a sense of who this impacts women and girls, this impacts medical providers, this impacts anyone who aids women and girls seeking an abortion. And what that means is that they can get women and girls, if they get if there is some sort of perception from a medical provider or from suspicion from somebody, they could call law enforcement and they can get imprisoned for many years. Medical providers, if they perform any sort of medical procedure around abortion, they will also get imprisoned and punished by law. And anybody that provides any financial aid or support to somebody who's seeking this procedure, they would also get imprisoned. And I wanted to give a story of Manuela, because Manuela really brought this to the attention of the United Nations and how El Salvador was condemned by the United Nations. So Manuela was experiencing an obstetric emergency. She experienced miscarriage, and she went to the hospital to seek care. And just to give you a sense of the health infrastructure in El Salvador, there is specifically one hospital that provides women's health care overall in El Salvador. And in terms of travel, what that looks like is when I would fly into Salvador, I would fly into San Salvador, and it would take me 4 hours, or take my family 4 hours to get from San Salvador all the way to La Union, which is on the other side of El Salvador. So there's one hospital, so that gives you a sense of what the health infrastructure looks like there. And so when they saw that she was experiencing that, they presumed that she was that she performed an abortion, and so they imprisoned her. So she was separated by her family. She was separated by, she lost the opportunity to live a life because of a presumption that somebody made and she was in prison, and she ultimately passed away while she was in prison because she had undetected cancer. She didn't receive any access to care. She didn't receive any access to any treatment to support her care outside of her experience around the obstetric emergency. And so this really called upon the United Nations to condemn El Salvador for this very extreme law. And just to give you a sense of what this means is, as I was doing my research, there was another specific number that I couldn't believe it when I saw it, but 56% of providers in El Salvador notified legal authorities if they suspected any unlawful abortion. So there is a huge patient mistrust with medical providers. There is a lot of contention around or strain between the relationships to even talk about menstrual health, to even talk about sexual and reproductive health, to even talk about family planning, which is so critical with communities when having these conversations with their providers to ensure they have equitable health outcomes. So while as you talked about, Gabby, that number around 54.4% of sterilization, I think we need to dig deeper into that number, because there are some women that decide that for themselves. But what I think there needs to be further research is, has these laws led this to coercion, to mistrust, to fear due to these laws? And we have to also acknowledge that there are women that want to make these decisions for themselves, but when there's a policy that's put in place that ultimately leads to fear and mistrust, to scare because of that they could get separated by their families due to imprisonment. They don't seek care because they get scared if the provider is going to notify legal authorities. I think there needs to be further digging into what the ultimate impacts and what those downstream impacts of what these laws can mean for for women's empowerment, for their decision to make sexual and reproductive health decisions for themselves and for their families. All of these contextual factors around patient mistrust, around what providers actually counsel. There was a specific article that I found that some women were saying that they were having campaigns in their communities around sterilization, that they weren't given any other option around modern contraception, such as IUD, birth control pills. And there's definitely assumptions.
That was the public health response to do a campaign around sterilization?
So that was a woman's experience. I don't know if that was a public health response from the actual clinics, but when there was interviews being done with women in El Salvador, one woman specifically stated that they saw campaigns around that was pushing sterilization. And so that's another aspect, is we need to dig deeper into all of these different factors, because right now, and that's where my interest continues to lie, is continue to research this and what this means, having these conversations with women. What are the policy implications, and what this means overall for women's health? And so just to also give you another interesting fact is, El Salvador is one of 4 countries that has rolled back abortion laws. In that other 4 countries, United States is also aligned with these rollback, as we know. And so I want to pass this off to Bridget, but before I do, in terms of what that means in terms of migration, if we have women coming from El Salvador to the United States, they're coming into a similar ecosystem around sexual and reproductive health because of these rollbacks on reproductive health rights. So there's, as we have these ongoing conversations around health equity, around human-centric healthcare, around culturally affirming healthcares, can providers be prepared, or how are providers prepared to have these conversations with women that are migrating to the United States from El Salvador? They might have these similar experiences. There's also continued patient mistrust. So what does that mean for women when they come here? So Bridget, about more about this.
I'm like still stuck on the story you shared about what I would deem as almost forced or coercive sterilization at that point, whether it was born out of fear because of a policy, then if that's the only option you feel, instead of running the risk of potentially needing an abortion or miscarrying. Like that's got to be compounded.
I mean, what about like ectopic pregnancies?
Right. Right.
You know, or I mean, or no, I don't know. You
Yeah,
fall
there's a
off
lot.
the bus and you hit yourself and you miscarry.
Right.
You know, it's a lot. It's a lot to process. Go ahead, Bridget. I'm sorry.
No, I agree. And I think I also, whenever I hear this, I process it as well, because it's terrifying to not be able to access the care that you need to save your life, but also potentially save the life of the baby you're trying to carry too, out of fear that you will be accused of an illegal abortion. So I think what you said, Kelly, is also reminding me, like, just like you said, the U.S. is out of step with the rest of the world in making progressive movements towards more liberalized reproductive health and rights policies. And like you said, we're one of 4 countries rolling back. But what implications does that have for people migrating from Central America, from countries that potentially, like Honduras and El Salvador, that have restrictive abortion laws, and then coming to the U.S. To be greeted with potentially restrictive laws too. I'm thinking in particular of Texas with the SB 8 law,
Right.
that is pretty much in line with the El Salvador law too. I mean, there's a 6-week grace period of availability. So, it's pretty terrifying, honestly. And we know that there are several reasons people choose to migrate or are forced to migrate, and they are all of the reasons are diverse, just as diverse as the communities coming. So we have climate change as a major impact,
Right.
food insecurity, environmental degradation, poverty, inequality, crime, and violence. But one thing that I think is really key to all of this, that a lot of policies tend to overlook, once again, is the gender inequality aspect of it.
Right.
And how that relates to these other major themes, and what impacts that has, because we know when there's major events formed by climate change, so like hurricanes or earthquakes, violence tends to go up.
Right.
Gender-based violence tends to go up. And that also includes sexual violence. And so what do these spikes mean for people coming to the U.S. in need of care, but then greeted without access? Yeah, some pretty big question marks there, I guess.
Right. It's so much. Actually, since it's just a couple of us, does the audience want to hop in? You've put some pretty powerful comments in the chat. We can keep going. Okay. So when Bridget, actually, well, you've touched on a lot of this, but you really, when you and I first started chatting about this whole topic, discussing sexual and reproductive health and rights, we also talked a little bit about how it was so important to other areas. And then we went on to discuss restrictive reproductive health policies, but also like sort of some of the movements that are also happening, because it's not all a bad story.
No,
it's really interesting things happening where, there's increased restrictions, but at the same time, there's liberalizations of reproductive health. Tell us a little bit about that aspect.
Yeah, I
There's really
agree.
a contrast.
It is. And we're talking about the restrictions, you know, here in the U.S. and in El Salvador, but it's really important to highlight the liberalization and the progress that's being made in many countries in South and Central America through the grassroots green wave movement, which we have a lot to learn from. So a group of grassroots activists formed not by legal experts or sexual and reproductive health advocates, but really formed by students and teachers and artists and singers and community members. They donned the green bandana as a way of masking their identity. But it's such a powerful movement that started in Argentina and inspired lawmakers to listen to these activists and decriminalize abortion, and in fact legalize then. They went further than just decriminalizing it, went further to legalize it up to 14 weeks in Argentina, and that sparked something, and it just spread. The movement has spread, and so we're seeing similar
women in the street singing and dancing and just putting it out there in their bandanas.
Yeah, and in fact, the bandanas are now moved to the neck. Even it's more
Hair.
or the hair, yeah. So I think the one thing that gives me a lot of hope in seeing this is that these are areas where it has been a very restrictive policy environment. And so we're seeing this progress moves, like Mexico. Gabby, you and I were talking about this year. They've included reproductive autonomy within the right to reproductive autonomy within the Constitution. So now if anybody tries to implement barriers to that right, that will be deemed unconstitutional. So what can we in the U.S.
such a big leap for Mexico too. I mean, from our tradition, so I'm being Mexican now, but from our tradition of just, the macho image and the woman subservient to the man, to where we are today. It's a huge move. And hopefully it'll impact, because that's a huge move in Mexico. Also, the other contrast to that is extreme femicide.
Right.
So, which also plays into this, but I don't want to go off on that tangent.
I mean, I do think there is a big connection there, though. So if you do want to highlight that, I think that's rather important in these discussions too.
So, okay, so gender inequality, we started with that, because that's at the foundation of this. And how has it impacted, like, socially, politically, and economically? What do you think El Salvador is seeing or could see, Kelly? And what do you think it means for us here?
Yeah, so I definitely see, through my literature and just even through my own experiences and having conversations with Latino communities and seeing kind of what putting these themes together as when I'm working with communities. And there's a lot of stigma, when we don't have these conversations, there's a lot of stigma that continues to penetrate the communities. There's a lot of, again, mistrust that happens within our healthcare systems. So what that means for quality of life outcomes in terms of El Salvador, their infrastructure, their healthcare infrastructure just doesn't have the capabilities to, I think there definitely needs to be more understanding of how their infrastructure even works, to even understand what the abilities of access to some of these, to other sexual and reproductive health, such as tampons, pads, what that means for, their pap smears. Do they have access to that? Will they not get access to that because they're scared that they would find something? And so what that means in terms of the implications around girls, when I was when I was doing my review, I found that a lot of younger populations were getting sterilized. And so what does that mean for their own perceptions of what they hoped and dreamed to have as they grew up? Are there any barriers that they're going to continue to experience around education? What that means in terms of them going into the education, going into professional opportunities, and having that economic empowerment.
Mhm.
And I'm having these conversations, and you know, when I talk to my mom about it, she tells me all the time, like, she didn't know anything
Right.
until she came to the US, and she was about 18 years old, and then she kind of understood like what she heard from others, and like what that word of mouth was, what people were talking about. And she was like, I didn't know any of this. Like, I didn't know I had to go to a yearly office visit with a gynecologist to go to take care of myself. I didn't know I had these options for myself. How do I get to select what's the best option for me when I don't have an understanding of what education is out there for them? And as we know, that there's a lot of, especially here in the US, there's still so much work to be done around language access. To your point, Veronica, like, language access is such a huge barrier. You know, in El Salvador, do they have the education? Do they have the ability to provide sexual and reproductive health education? But what constraints can they come with if there's a policy that doesn't allow them to have certain conversations?
Right.
And so as we think about the communities here, as we think about what's happening in El Salvador, there's a lot of lessons learned that the US can take away from there, to understand what those downstream implications of policies mean for communities. Because times we make these movements in policy, but we don't understand what are the trickle-down effects and what that actually looks like in communities themselves.
Right.
And so as we're having these conversations, I think it's important to put at the forefront what Latino communities, what their understandings around sexual and reproductive health rights are, what they're empowered to do, what they need to be able to bridge those gaps around language access, so they're more informed to make those decisions for themselves. I think in Salvador, you know, I will not minimize like that there are people in El Salvador that are working towards, and so I thank you, Bridget, for sharing an article around an organization in El Salvador that's really pushing the limit around this. They are actually, it was somebody that actually experienced imprisonment herself due to this perceived, that they perceived that she was having an abortion. And she started an organization where she's bringing in women that are being released from jail to help them secure that economic empowerment. They're going through trainings, what this means for their lives. They have support groups. They are really trying to, you know, going back to the Green Wave movement, there are organizations in this world that are really trying to push this and to make changes in their communities. But there is so much more work to be done. I think in terms of El Salvador and what for the US, we have so much work to be done. There's so much work to be done here. I mean, to your point, Bridget, around Texas, like when there isn't a national blanket to really protect the rights of women, you have states that are picking and choosing what makes sense or what the political winds are looking like there. So now we have this huge backtrack on certain states like Texas, where people are also experiencing the same thing around mistrust, around scare of what they can do for themselves if they experience something that could be punishable by law. So I think there's a lot of implications there, a lot of lessons learned to be looked at. And it is, you know, I think there is positives around this, where there are people like Bridget, like myself, like you, Gabby, like Veronica, we're all champions around this work, that we really can use our voices. You don't have to be a sexual and reproductive health expert to advocate for women's rights and advocate for girls' rights and sexual and reproductive health rights.
Right. So we're down to about 7 minutes. Usually I hand over to Veronica at this point. is there anything you ladies would like to add before I hand it over?
Sorry, I just opened the chat, and so I saw your comment, Veronica, and I really appreciate that. And I really like the question too of like, what are some of the practical steps that we can take here in Maryland and locally. And I think that's so important when we talk about these like international policies, like, okay, but then even national policies can seem so out of reach. One thing that sparked in my head was that my hope is that we can start seeing sexual and reproductive health and rights as a prerequisite or foundational aspects of girls' education, of healthcare, of economic empowerment. And so, like Kelly said, we don't have to necessarily be dedicating our jobs to reproductive health and rights to help advance the movement. You know, we're talking about what we can do to ensure that people with limited English proficiency can have access to this. My mind goes to, well, what does the provider demographic look like? Are there enough Latino providers that are able to provide the services needed to ensure that women have access? And so even if there's not this direct link to that, people should be working on making medical school more accessible to wider populations. This is all so interconnected that little work else in other places means a lot to the movement itself. And so I think that's really key when thinking about this, is identifying how reproductive health really influences your work. So if you're working in schools, like, are there provisions of menstrual products? Is there comprehensive sexuality education? Is there something you can do to advocate for that in the schools? But if you're working on economic empowerment, like, what aspects are there? Are women being given leave for maternity care? I mean, it's not great. The status of maternity care in the US is not great. And Kelly, the mere fact that you had to leave a job because you could not feed your child, that to me sounds criminal. Like, I just can't, like, how is this allowed? But it is. And so these are other issues that we can work on and advance to advance the entire movement.
Well, this is a lot of food for thought. And I really appreciate both of you, your leadership and your courage. I love that you're doing this work, and you know, it's good to hand it over to the next generation, as they say. I'm Veronica. It's all yours.
Oh my God, why do you guys always do these hard things?
Because life is hard, but we always come together. We can find solutions.
No, I love it. I love it. And I appreciate the intentionality of the response. I appreciate you ladies so much because this is a topic that no one ever talks about. So I don't know what it is. And of course, I'm the inappropriate one that doesn't have any filters. You see how Gabriela prepares beautiful remarks, and I rarely do. And then I just always get in trouble. But I am fascinated by the fact that, you know, it is not, access to menstrual products is not the norm, that there's taxes, that there's inaccessibility. And, you know, I think of my own daughter who has such a heavy flow, she can't function. And I'm always distracted on Instagram when you see these period testers on men, and they ramp up the level and they go from 1 to 10, 10 being, you know, epic back crap, you know, insanity. And then 2 or 3 is everyday period cramps. And at 2, men are crying for mercy. So, you know, you're thinking, you know, if you see that, why do you restrict access to medicine, to treatments that can facilitate the ability for us to contribute? We're 50% of the population.
Right.
We are contributing. So one of the biggest concerns I have is the impact to our immigrants the girls that are growing in households of immigrants. Obviously, this restriction of resources impacts their career growth, their self-esteem. You know, aquí lo mencionó Kelly that I had to switch jobs. I remember breastfeeding, pumping in a dirty bathroom, and I didn't think anything of it. I was like, oh, this is my lot in life. So I have the pump as I'm trying to work, and I'm thinking, why is that okay? Digressing. I think we, as a group, need to be a lot more strategic. We have friends in legislation. I think we need to be proposing more bills that ensure access. We need to look at the basics, you know, definitely leveraging Bridget. Like, I don't know if you have a toolkit, Bridget, but is there a basic that, you know, how Baltimore City was elected one of the top immigrant cities in the country because they passed certain categories? Is there a list? Are we supposed to have mandated nursing, mandated pads, mandated blah, blah? Like, what are the 10 things that every city, jurisdiction, municipality is supposed to have? And if they're not standardized in Maryland, let's propose that as a bill so that we can force people to, because a lot of people, men don't know. You know, I know we have sympathetic allies, but they're in the dark about, no, it can't hurt that much. It can't be that much blood. Until you bleed through your clothes and they go, oh. So maybe they don't
Then
know.
they faint.
Then they don't want you to be seen. They don't
Right,
want
right,
to
like,
see
oh, I don't want to
that.
talk about that. Let's go. Freak them
Sorry,
out.
guys. There's gentlemen on this call, on this conference.
No, and I respect we have allies, but to be perfectly frank, until my daughter would cry, I was like, how hard is it, baby? Because my periods were never that bad. So I was dismissive myself, going, oh, can't be that. Come on, baby, just take a pill. You're good. And then I'm thinking, oh my God, I'm doing what's always been done to us. So lesson learned, you know, holding up that mirror. But is there a toolkit we can develop, create, steal, borrow, and then measure every municipality to that? And if there's no standardized access, coño, let's push. Let's absolutely push. And then I think somebody mentioned briefly is education. Our ladies.
Yeah, sharing laws, policies that are being considered.
At the middle school level, we need to be pushing and talking openly that this is completely normal. Boys need to hear that this is normal. Just like we sneeze and we grab a tissue wipe, but no one laughs at you. So if I excuse myself, no one should be giggling. If I bleed through my pants, should be completely normalized. So I think we need to start doing this. And I know Al-Marie mentioned that there is a upcoming health training. So to just wrap us up, I know we're a little bit over, is let's unify in what I think we should be 50 years ahead on this. But let's do whatever Bridget is doing at a national level, apply it to Maryland, push, and then just look for easy fixes.
Kelly, we can do this with MLU, your next project.
Serio. And we can reach out to a couple of bigger partners and ask for funding as needed. But this is basic. We're 50% of the population. And I mean, I think
we need to start acting like it.
And it ties to mental health. We didn't even touch into it at all. We have all the trauma of migrating and your parents, right? And the challenges of adjusting with your parents. So I think this is a tool and resources we can provide to our younger folks. And in our capacity training, Gabriela and Al-Marie, including, you know, maybe we don't train on it, but we talk about it. And these are the areas to be aware of. So if there's any auxiliary services, the nonprofits and the community-based organizations can kind of go, oh, we never thought how mental health is triggered by lack of access. Yeah, we're not even talking about abortions. Even before that, to Bridget's point, the simplicity of that.
Mental health. Women's health. Like it's
with Thanksgiving being next week, you know, I am so grateful that we have folks like you that are in the front line. And sometimes in the dark rooms that we're not even supposed to be in, fighting and advocating for stuff that no one thinks is sexy. So I think it's a gift to have you guys in our lives advocating. So muchísimas gracias.
Gracias. Thank you, everyone. With that, we wrap up for this afternoon and pre-Thanksgiving. I'm grateful to everyone who showed up. We'll post this on our YouTube channel, and I think it needs to be shared broadly. We definitely have homework, lots and lots of homework. So this is
Well, and
just,
I'm looking forward to continue to collaborate too. So
you're drafted.
I don't think you can
I'm
escape.
honored.
Get
Thank
ready.
you so
Yeah.
much. Yeah.
Get ready.
I told Bridget, I told her, I was like, once you're in with MLU, you're not leaving. Like you gotta.
We're not playing. We got a lot of work. to do.
I'm here. I'm here. Thank you.
Well, thank you all so much. We look forward to seeing you next time. Yeah. I believe it's December 14th. Susanna, is that right? Is our next session?
It is
Susanna, I'm sorry?
That is right.
Ah, see, my memory is not as bad as I thought it was. We look forward to seeing you on December 14th to wrap up the year. We're at the end of our year. Thank you for being with us throughout this. We look forward to collaborating.